suppose we have everything pointing away, both pointing downwards, then I have an axis in Pakistan, which is the northwest axis. So if you quickly look at lead 1 and lead doesn't matter to me. That we can go to later, but I already know quickly that this is an abnormal axis. Now, one of the most important things which have come out in modern times is the prolongation of QT by many drugs, electrolytes, which we many a times miss. And I have seen amiodarone given to people who have hypokalemia and people precipitated with a torsades-de-pointes. So it is very important for us to recognize whether the QT is prolonged, because many antipsychotic drugs, many of the drugs today prolong the QT and it can result in sudden cardiac arrest. So I want you to look at the QT interval for all patients, especially when you are in the ICU. You have to look at it. If you miss it, then you're going to create a problem for the patient. So how do I look at it? I call it the 50% rule. 50-50, crackjack. So let us look at it. If you see a QT interval starting from the beginning to the end of the T wave in lead 2, possibly, if it is more than 50% of the RR, then very quickly you have made a diagnosis of QT prolongation. And if you have made a diagnosis, if it is less than that, possibly you are not dealing with a QT prolongation. But if you have found this out, then you can use the Bazar's formula to get the accurate QT interval. If it is less than that, I don't need to bother with the Bazar's formula trying to calculate what is the QT interval. It doesn't matter at all. So 50% rule. Please remember 50% rule. Just look at it, eyeball it, look at RR interval. Is it 50? At the most, what you can do is you can put a caliper. You can take a piece of paper, mark the RR interval, fold the paper and keep it here. So the middle of that will give you. It's very easy to take a small sheet of paper and do this. So we are finished with the QT interval. Quickly you are finished. You are on to the next. Now the next thing is the chest leads in the normal or abnormal? Are they showing the normal activation and depolarization? So I look at the R and T waves and ask who is taller. Where is it taller? Is it taller in lead V1 or V6? The normal is V6, the T waves and the QRS is taller than in lead V1. Why? Electrical forces are flowing away from my right shoulder towards my left foot. So the activity is going away. Actually, the lead V1 is an intracavitary lead. It is looking inside the cavity. So many a times you will find that all complexes are inverted. Along with AVR, V1 is another intracavitary lead. It's looking at inside the cavity electrically. So it is very easy to identify. Now suppose you have something which is reverse than this. Let us look at it quickly. Of course, you can do in the meanwhile, you can quickly calculate the rate. You can quickly look at the P wave, big box rule. Two contiguous leads is myocardial infarction. ST depression in two contiguous leads is myocardial ischemia. So if you identify this, very quickly you can identify, you can use the other rules to come to this conclusion again. So I call this the eyeball technique, the 10 rules which you need to apply to very quickly identify what is normal or abnormal, heart rate 3 to 5 and the big box rule. P waves, lead 2 taller than lead 1. AV conduction, 1 large square rule. AV conduction 2, who is related to whom? QRS duration, 3 little box rule. Find out in wide QRS where is the traffic block. Look at the rabbit ears. QT interval, the 50% rule. R and T waves, who is taller? Abnormality, you can look at V1 and V6. And ST segment, the 1 mm into 2 rule, and there you are. You have finished your ECG reading. And in conclusion, ECG is widely available and provides useful information in a variety of conditions. Stepwise analysis is crucial to get useful information. The 10 ECG rules serve as useful tools to identify normal from abnormal practice of these 10 rules allows rapid bedside reading of ECGs. And in the end, I want to leave you with this, which has been written by none other than Willis J. Hurst, who is the author of a textbook called The Heart. Now, this was written in cardiology clinics. To perform a procedure and not be able to interpret the information yielded by the procedure is called pretense. So we are pretending to be, because the patient thinks that you have ordered an investigation and you are able to identify it. The patient believes the physician knows how to interpret these things. Many physicians do not know and believe that they can interpret electrocardiograms. So he calls this chapter as Interpretation of ECG, Pretense or a Well-Developed Skill. Thank you all for a patient hearing.
Ladies and gentlemen, agree with me that Dr. Jayaprakash has made it very simple for us how to quickly read the ECG. This is particularly true for resident doctors and junior doctors. They should not fall for this computerized ECG, which can mislead you many times. If you apply these 10 rules, you can quickly find out whether they are normal or not. Thank you, Dr.
I now request Dr. S.B. Gupta to further state our speaker, Dr. Jayaprakash. Request Dr. Jayaprakash to hand over the certificates to the chairpersons.
To further enhance our basic knowledge of an ECG, we have next session chaired by Dr. C.B. Patel, Professor and Head of Department of Cardiology of St. John's, Bangalore. Dr. A.V. Shetty, Retired Professor of Medicine, KMC, Mangalore. Dr. Ravindra Reddy, Professor of Medicine at Pratima Institute. I request you to take your seats. I now invite the speaker for this session, Dr. Ketan Mehta, onto the dais to speak on misleading recordings, artifacts in ECG, how to recognize it. I kindly request the chairpersons to introduce Dr. Ketan Mehta.
Good morning. I think after Jayaprakash's speech how to interpret an ECG in a rapid way, let us see what is sometimes looks like abnormal, that is artifacts. And these may be due to muscle tremors, hand movements, loose electrodes, cable problems, electromagnetic interference. So many things are there which can mimic like an abnormalities, and sometimes junior doctors may mistake it for some arrhythmias. And people have given shocks also in such conditions, thinking that it could be an atrial fibrillation or a VT or these things. So let us just learn from Dr. Ketan Mehta what are all the artifacts which you can see and who should try to. And Dr. Ketan Mehta is working in Asian Heart Institute and also Raheja Fortis Hospital and Balabai Nanavati Hospital, 7 Hills Hospital at Bombay. He is Honorary Joint Secretary of ICP and Joint Secretary of ISC and NSPR, that is a preventive cardiology this thing, and is a trust board member of MMA, HSI, MMA, and he is also a organizing secretary of Diamond Epicon 2005. With this little introduction, I request him to speak.
Respected chairperson, my senior colleagues, and ladies and gentlemen, it's indeed a pleasure to be here at the midterm ISECON, and I'm going to talk on artifacts in ECG, how to recognize them. You know, it is really an honor when speaking in front of none other than Professor Dr. Martin Green, who is over here. Sir, it is indeed an honor to speak on that. As Dr. Jayaprakash has rightly said, you know, the first bedside diagnosis, you are going to identify what is normal and what is abnormal. So is this a normal ECG or is this an abnormal? Can I have that trace? Is this a normal or an abnormal? Now, once you have picked up abnormal ECG, you need to find out whether are you dealing with a false positivity, because that's very important. Once you're detected there is some abnormality, is this true abnormality or is a false positive? So, you know, when you take any ECG diagnosis, it is valid only if electrodes are placed in correct anatomic locations, lead wires are attached to appropriate leads, because sometimes it may happen you have connected the 4 electrodes and so often in hurry that the ECG technician, staff nurse connect one electrode to the another leads, and then, you know, it becomes a totally mismatched. The recording has to be of a good technical quality with a proper filtering and absence of extraneous electrical noises. Then you can have a good ECG recording. Now, especially it is important when you are going to have a serial ECG interpretation, because the consistent technique which is important, electrodes has to be in the same location, especially when you are putting on a chest leads, from V1 to V6, and if the position is changing little bit here, you will have a different tracing, and people will compare yesterday's ECGs with today's ECGs, and then we will feel the difference. So often in the institutes now, they mark out the position that this is where, okay, you are going to put a V1, V2, V3 to V6, and so that same position, the chest electrodes are placed subsequently. Patient's body in same position, because sometimes, patient is acquiring is orthopnic, taking a ECG, again it will make a variation. So you need to see whether each ECG is taken in the same position, then only you can compare supine versus, propped up, you may have some variation. And of course, using the same lead configuration. Now, when we talk of artifacts in ECG, they are classified that artifacts which can arise from internal or external sources, internal which is physiological and external which are non-physiological. Now, let's see what are those artifacts which is internal, what we talk of physiological, which is could be due to muscular activity, which of course allows electronic filtration. There are small spikes, we will see the ECGs. Then it could be due to patient's motion. So it does not allow electronic filtration, especially epidermal stretching, which will produce this type of tracings. And of course, the tremor induced, especially patients who is having tremors due to whatever reasons, you will have those artifacts. Now, if you see, this is a classical ECG of movement artifacts. You can see that, can I have a pointer? You can see the ECG which has been shown with the normal QRST complexes, and suddenly there are things are happening. So you might wondering, is it arrhythmias or anything? But you know that earlier and the following that complex, you have got a normal PQRST complexes. So this is the movement artifacts which has come up over there. Then, of course, in Parkinson's patient, so often Parkinson patient does not mean that they cannot have any cardiac abnormalities. They get admitted to, comes to emergency room or comes to casualty and has got, increased movement at that time. Parkinson is uncontrolled, and you will see such arrhythmia. Now, again, you need to identify that this patient is in the sinus rhythm, and if you pick up that this patient does not have arrhythmias, it is because of his uncontrolled Parkinsonism, he is having those arrhythmias with. Then sometimes patients having rigors, coming to the hypotension, coming to emergency room, and you are obviously, as a standard protocol, you take all the investigations. So this is of course, due to somatic muscle tremors, which is coming in the multiple leads, you will see all across most of the leads, you will have those artifacts, small spikes coming up. And you know that these are definitely the artifacts which are there due to the somatic muscle tremors. Now, talking about the external causes, that is, you can have due to electromagnetic interference, which is the most common thing. So often, even when you are traveling in a car, and especially the radio is on and your mobile is coming, you will get that vibrations from the radio itself. That is nothing but your disturbance due to electromagnetic waves. So power in the electrical disturbances or light fixtures, electrocautery, which is being used because especially patient is in ICU, nearby places, so many other gadgets are being used. Electrical devices in the room, then radio frequency based commercials like mobile phone products, as I was just mentioning, this will produce artifacts in the ECG, maybe in the actual graphics or also on the recordings which has been done on a monitor. Then cable and electrode malfunction. This is again very important. When you have a nice recipe to be, you know that you're going to have a nice pasta or a pizza, it tastes good, but then what is more important is the person who is preparing, and I'm sure the ladies will know, your husband might complain that today it is not good. So it is the cook who is preparing is very important. Similarly, the ECG was the person who is taking the ECG has a pivotal role in delivering that and can give you the right picture. So you have a insufficient electrode gel, which is very important. Sometimes too excessive or too less, of course, that will be giving an erroneous reading. Misplaced leads, as I already mentioned, inappropriate filter settings, which is their broken wires, half wires it is broken, loose connection, and of course accumulation of static energy. This will produce this. Then medical equipments in operation, when patient is in OT or in ICU, the various equipments, as I was mentioning, can also affect the EKG monitoring system, especially electrodes, leads, amplifiers and filters. Now, this is the electrical interference from a nearby electrical appliance which has been kept. A typical example of 100 Hz background distortion from a fluorescent light. You may feel what is there, that is nearby happening, but that itself can be confused. Can you see? It can be confused so much like whether it is a atrial fibrillation or what. So you need to see that this is something which is happening that is not actual pathological. Another example of an artifact which is caused by electrical appliance, the rhythm is regular. Now, if you see the strip over here shows the QRS complexes, but in between there are complexes coming like this, and you might feel, is this pathological complexes? No, these are artifacts. So here you know that these are all complexes which are coming at regular intervals, but these are nothing but artifacts which are coming on that. Now, let's come to the technical problems, which is of course where we know the person who is behind the ECG machine or person who is taking the ECG is very important. AC mains interference, which I already mentioned, you have most of the leads showing those small spikes. Wandering baseline. Now, if you see, how the baseline is moving over here. Now, this is wandering baseline. It is again, it is artifact. You are not talking of any arrhythmias or anything. Now, wandering baseline is nothing but the cables moving during the recording. You place the cables, and those cables are long wires, and it is moving even while the recording is, tracing is being recorded. Patient movement, of course, it will cause the movement of the cables. Dirty lead wires, electrodes not been cleaned regularly because that is required. Sometimes those ECG jellies which stick to the electrodes, and then same can produce such things also. And of course the loose electrodes, sometimes the staff has not properly attached to the cable, the cables. So all these things can produce such artifacts. Now, baseline drift, you see such recording, and especially when what is happening, you wonder why this ECG is going like this and up. Now, if you see, of course, it is normal complexes which are there, but this happens especially when there is a change of lead, especially in certain ECG machines, when you take a long lead 2 and then suddenly you change over to another lead. For initially, you might have such type of baseline drift, or especially it occurs when the patient has been given shock and subsequently reverts, you can have such a drift which is happening in the baseline. Now, this is an ECG. If you see suddenly, first thing you might wonder, is it what the earlier speaker has already mentioned, you first diagnose whether it is normal or abnormal. Oh no, you feel this is abnormal. Then the next question is this truly abnormal or a false positive abnormalities? And obviously you can see this is not a ECG of atrial fibrillation flutter, but there are a lot of artifacts which are coming up over here. Now, when you see these artifacts versus a true arrhythmia, you need to differentiate it. And it should not happen that you label this anyone as an artifacts and they turn out to be a real arrhythmia also. So obviously the morphology is important, but there has been incidences, what sir has already mentioned, that at times people have received a shock in ICU unit, seeing the certain ECGs over the scope, and has been given. I remember one incident, and one of the residents in a hospital just sees on a scope some fibrillatory waves and suddenly asks for a sister, get the defib, and then the other doctor luckily happens to be there and sees, the patient is Helen Harty. So he just sees the monitor without realizing the patient is Helen Harty sitting over there. This could be artifact. So another incidence is when happens now you have got a computer synthesized rhythm is there. Now if you see such ECG, first instance you will start thinking, there is a broad complex tachycardia is there. You wonder what is happening, but if you see the row rhythm at the base, what is happening? There are isolated PVCs which are coming, and what has happened? There is a computer synthesized rhythm which is there, which is generating and giving an impulse, image that you have got a broad complex tachycardia. So it's not broad complex tachycardia. If you see the raw ECG, you can diagnose that these are not this thing. So there are certain points I would like to tell in artifacts is differentiating from ECG, the artifacts versus the real disease. Once you have absence of symptoms or hemodynamic variation during the event, person is, not having any complaints, no palpitation, no chest discomfort, no breathlessness, his blood pressure is well maintained, he is unlikely to have a real or pathological problem. The normal ventricular complex is appearing during the dysrhythmic beats. You have to see in between whether there is a normal complex is appearing. Then of course this is a more likely a normal variant on that. Then association with body movement, you need to see how the body is, what the patient is doing at that time. Instability of baseline tracing during and immediately following the alleged arrhythmia. Again, that will give a clue, and synchronous visible notching consistent with the underlying ventricular rhythm which is marching through the pseudo-arrhythmia. Now what we call those as pseudo-arrhythmias, which are not actual arrhythmias, which will be do. Now there is a nice article Huang et al. Has described there are 3 signs differentiating artifact from ventricular arrhythmia. First one they have said is the sinus sign. What does it say? One of the frontal leads, either 1, 2 and 3 may present with sinus rhythm which shows normal P, QRS and T waves. The reason given is that one of the upper limbs may be free of tremor. Second is a spike sign, that is presence of regular or irregular tiny spikes among wide QRS complexes. Those are various spikes we have seen in the previous ECGs which were there. And the third one is the notch sign, that is notches superimposed in the wide QRS like complex artifacts and coinciding with the cycle length. So cycle length remains the same when the sinus rhythm was recorded, and these are the 3 signs which can be seen in an artifacts also. Now coming to briefly about the lead misplacement, again commonly observed especially in ICUs, in emergency room. You know how the leads are placed, you are aware of them, and how the leads are recorded. Now what happens, you need to identify and see, at least you can able to pick up, okay, no, this has been misplaced, or these are the leads which has been wrongly connected. Now remember, if the complex in lead 1 including the P wave appears upside down, the left and right arm leads are reversed provided the precordial leads are not suggestive of mirror image dextrocardia. I am going to come, because that's going to be a differential, whether it is a RA-LA switchover or it's a mirror image dextrocardia. Now here what happens in the lead 1, once it is inverted, obviously and this is the graphic recording, you will get it in lead 1, you will have everything negative, P, Q, R, S, T negative, which you are not going to get it otherwise. So here RA, LA is reversed, but only thing is you need to differentiate whether it is a true mirror image